Sorry, guys. All right, so this is Lindsay Luther. We're going to get started with our HEENT Red Flags and Emergencies presentation. I think all of these conditions are things that could show up on your boards as far as questions that you're asked. And so I think it's important to be able to identify whether or not an HEE condition is an emergency or if it's something that you can easily treat in your office. So eye problems are going to account for about 3% of all of the visits to primary care providers and emergency facilities. And so you need to recognize when an eye complaint is urgent or emergent and when it requires a specialist involvement, and those conditions that you can treat either in your office or help your patients to treat at home. So we're going to start with the red flag conditions. In order to determine if an eye condition is urgent, you will do a 5-minute, 5-part physical assessment of the eye. So you're looking at visual acuity, the pupil's response, an external ocular exam, extraocular movements, and the retinal exam. So specifically, when you're doing each of these things, you want to be aware of any sudden decrease in visual acuity that the patient has experienced, any changes in the pupil, such as distortion in the shape of the pupil or a lack of responsiveness to light, any external trauma, a foreign body, or the presence of a lid laceration. You want to be assessing the patient for sudden double vision or impaired eye mobility. So this is when you're doing your cardinal fields of gaze and other testing for peripheral vision, etc. And then finally, you're doing a retinal exam, primarily looking for papilledema, which is the biggest concern that you will see because it indicates that there's swelling behind the eye and potentially in the brain as well. So there are some findings which are emergent, and then there are some which are urgent, and these are things that you should be able to identify so that you know whether the patient needs to go to the emergency room or just to see an eye professional within the next 24 to 48 hours. So if a patient presents to you with a chemical eye injury, the very first thing you're going to do is irrigate the eye. So before you send them to the ED, you're going to irrigate the eye as much as humanly possible. You should check the pH of the eye if you're able to do so, if you have a pH strip, and you want to keep irrigating until the eye is back to a normal pH. The faster you clean out the eye, the lower the chance and severity of the injury. Most chemical injuries happen either in workplace-related or home-related accidents. So this includes childhood exposure to abrasive chemicals, particularly cleaning solutions that are kept within the reach of children. So it's good practice as the primary care provider to be talking to families about securing these things which can cause injury. A ruptured globe, or the ruptured body of the eye, happens mostly due to trauma and usually will come with impaired vision and pain. If there's a foreign body present that has caused the rupture, for example, if there's something stuck in the eye, do not remove it. Don't touch the eye. Instead, you're just going to secure whatever is moving so that it doesn't move anymore, and then you're going to get that patient to medical treatment by an eye professional as soon as possible. A retrobulbar hemorrhage or a hematoma with high eye pressure can result from trauma. So symptoms of a retrobulbar hemorrhage include pain, bruising around the eyes, which we call periorbital ecchymosis, an eyelid hematoma, proptosis or bulging of the eye, visual loss, subconjunctival hemorrhage, nausea, and vomiting. The retrobulbar space, if you can see my mouse, is this area that's kind of back behind the eye, and it's surrounded by these muscles and bones. There's not a lot of space back there, so any additional bleeding will cause pressure behind the eye and force the eye forward. Over in your urgent findings, these are ones that need to be evaluated by either an optometrist or ophthalmologist within the next 24 to 48 hours. These are things like a hyphema, or which is seen down here. It's pooling of blood inside the anterior chamber of the eye. A foreign body that is not causing a globe rupture can be dealt with within 24 to 48 hours. These are pretty uncomfortable, and so most of the time these patients are going to be pretty motivated to get to an eye professional. An eyelid laceration should be dealt with pretty urgently. We don't always do anything with these, depending on how close they are to the eye and whether or not they're likely to heal themselves. And we want to be conscientious of scarring on the face. So sometimes it's important to get this patient to an eye professional, but an ER may be appropriate because of accessibility of plastic surgery. And then an ocular tumor, certainly if you identify an ocular tumor, you want to get that patient seen as soon as possible, but it's not necessarily an emergency room visit. And then a severe infection needs to be dealt with within 24 to 48 hours. There are some eye infections we'll talk about in a little bit, which we may tell you to send to the ED, and typically that's because we need these patients to have IV antibiotics. Not necessarily, it's better for facilitating care rather than they need to be seen within the next hour. Okay, speaking of those eye infections, one of those eye infections we worry about is orbital cellulitis. One of the key features of this is bulging from the eyes. The patient will have an impaired mobility of the eye because there's compression from the swelling. Their vision will be affected. So one of the primary ways that you're going to be able to tell if an injury can be treated in the office or needs to be sent on is whether or not there is pain in association with a visual acuity deficit. If there's a deficit in visual acuity, they need to be seeing an eye professional. Eye pain and tenderness is common with this, and then the patient can look pretty sick. Most orbital cellulitis results from a sinusitis that progresses upward towards the eye and into that eye area. The entire orbit socket will get inflamed, and this can require inpatient treatment. So this can threaten both vision and life. It can also, other causes include trauma, so something penetrates the eye, or the patient has a severe systemic infection that invades the eye. We need to get these patients identified rapidly, get them emergency treatment. Typically, because this comes from a sinusitis, especially maxillary sinusitis, the infecting organism is a respiratory bacteria, so that's the target of our antibiotic therapy, which we deliver through IV antibiotics. The patient can be evaluated once they're at the hospital with a CT with contrast to see the involvement of the eyes. You need to make sure that you differentiate orbital cellulitis from periorbital cellulitis, or preseptal cellulitis is the other name for it. Preseptal or periorbital cellulitis only affects the skin of the face, the eyelid, and the anterior portion of the preorbital area. It is not a deep infection that goes all the way back to behind the eye. Another infective condition of the eye is anterior uveitis. So this presents as a red eye with blurred vision. So again, you're going to have a change in visual acuity. They will not have photophobia, but they may complain of a dull ache, and the pupil will be abnormal. So that's another one of those red flags. If the pupil size is narrow or irregular in borders, then that's something you need to get seen by an eye professional. Anterior uveitis is the most common cause of uveitis, so you can have either anterior or posterior. Anterior is more common in healthy people, and it's more likely to be identified in primary care due to its presenting symptoms as opposed to the posterior. It can be caused by an autoimmune reaction, an infection, a tumor, trauma to the eye, or a reaction to a toxin. So this is something that you may see. Endophthalmitis is a little bit less common. This is a purulent inflammation of either the vitreous or the aqueous fluids of an eye due to an infection. We usually see this after cataract surgery, or if a patient has had an anti-VEGF injection. We can see this after trauma. This presents as progressive severe eye pain, a loss of vision. So again, loss of vision is a key warning sign. Red eye, you can see the pus that's pooling in the anterior chamber here, and there's swelling of the eye. So you can see the entire eye is kind of coming forward. So I wanted to include this this slide on shaken baby syndrome. Shaken baby syndrome is not actually a problem with the eye, but it is something that you might see in a child, and something you need to be aware of as somebody who takes care of children. Some of these patients will present with a reduced level of consciousness, but that can evolve over time. But one of the key findings of shaken baby syndrome is retinal hemorrhages in an otherwise atraumatic appearing child. This indicates the presence of acute subdural hematomas. They may have some metaphyseal chip fractures, and these patients need to be referred as soon as possible, and also this needs to be reported. Retinoblastoma is a tumor that can cause an abnormal reaction in the eye. So you can see here in this picture that when the light is flashed at the patient, the right eye is having a normal red reflex, but the left eye is having a white reflex. This is called leukocoria, and it indicates that there's a presence of a tumor. So this needs to be referred to ophthalmology right away. So this is the key red flag warning sign here is the absence of a normal red reflex. Neuroblastoma is another type of nervous system that occurs within the sympathetic nerves anywhere in the body, but it can result in eye findings. So these eye findings might include periorbital ecchymosis or raccoon eyes, or the bruising around the eyes in a child who has not had any history of eye or facial trauma. There's a syndrome called Horner syndrome, which I've shown you here. It's miosis, so narrow pupil ptosis, so drooping of the eyelid, and anhidrosis is a lack of sweating, and that's called Horner syndrome. The iris can change colors, and the patient may also complain of a unilateral nasal obstruction. So if you have a patient with symptoms like this, you need to be suspicious for neuroblastoma and get them evaluated. Acute angle closure glaucoma is an emergency of the eye. In this type of glaucoma, the aqueous humor is blocked from flowing through the pupil as it normally would due to damage to the trabecular meshwork. If the angle becomes blocked very suddenly, the patient can have a very rapid increase in intraocular pressure, and they will develop symptoms. These symptoms can last for a short amount of time and then resolve themselves, but then they will recur spontaneously. So sometimes they may have symptoms that only last for a couple of minutes, and then they go away before they can even present for treatment, and they think that it was just a fluke, but then they will come back. So this is something that needs to be on your radar if your patient mentions that they had these symptoms before. This is more likely to happen in a patient who has physiologically narrow angles, so if they've been told that before, they need to know about it. This is considered a true ophthalmologic emergency. It is actually pretty rare in practice. Most patients, as I said before, will have an anatomically narrow angles, and then their peripheral iris will be a little bit closer to the anterior chamber than normal, and this leads to contact and damage to that trabecular meshwork. So acute glaucoma is marked by the absence of discharge in a red eye with significant pain, a reduced visual acuity, and slight photophobia. The pupils will be either normal sized or slightly dilated. And you can see here how that blockage occurs in the trabecular meshwork, and it results in increased ocular pressure. Okay, so all of these things, for the most part, most red flag conditions involve some level of red eye. And most of the patients that come to your office with complaints of eye concerns will complain of red eye. So your job as the primary care provider is to tease out whether or not the red eye is something we need to be really worried about, or if it's something that's just benign. So unfortunately, a red eye pretty much looks like a red eye in most cases, and so you are going to need to rely on that history to determine whether the source of the red eye requires that emergent or urgent treatment. So the red eye itself is caused by dilation of the blood vessels of the conjunctiva, the sclera, or the episclera, or it can be caused by an accumulation of blood within the eye itself. The discharge that we see accompanying red eye is either caused by an exudate or transidate from the conjunctival blood vessels, or it can be caused by an alteration in the flow of tears. So there's either too many tears being produced or they're not being drained appropriately. Eye pain associated with red eyes will result from the stimulation of the conjunctival nerves, which presents as a dull ache, or it can come from stimulation of the corneal, ciliary nerves, or from inflammation in the sinuses, which are nearby to the eyes. So these are some questions that can kind of help you tease out the causes of red eye. I posted an article for you. Actually, I think I posted 2 articles for you which talk about the red eye evaluation and how to manage this. And this is one of the flow charts that are available to you. There are some really good options out there for helping to look at this. So these are some things you might keep in your phone, especially when you're just getting started in care. Sort of see what you need to do with these patients. All right, so let's move on to talk about some nasal emergencies and red flags. So we're going to start with red flags again. Some of the things that are potentially very concerning are so nose bleeding can be either a benign condition or it can be a concerning condition. We worry about nose bleeding that does not resolve with direct pressure on the bleeder, when it's recurrent and we don't know what's causing it, or if the patient has any signs of shock or significant blood loss. When we see unilateral nasal secretion in a child, the very first thing we think of is something up the nose. So if you see unilateral nasal secretion in a child, first thing you should be asking is, did you put something in your nose? Nasal polyps in children or unilateral nasal polyps are both abnormal and may indicate neoplastic disease, especially if there's also nasal bleeding or obstruction or facial pain associated with that. So that's down here, unilateral epistaxis. Nasal polyps in children are not common and can also indicate cystic fibrosis. Facial edema in conjunction with nasal symptoms likely increases the risk of a systemic infection and or trauma. So we want to keep that in mind as well. All right, so we talked about food items. One of the things I remember that one of my professors said when I was in school is that if a kid comes into your office with a complaint of something wrong with one of their holes, the very first question you should ask is, did you put something in the hole? So whether that's an ear, whether that's a nose, whether that's any other body part you can think of that has a hole in it, kids like to put stuff in holes. So the common items that we see are foods, so beans, peas, blueberries, cereal, buttons, toys, erasers, beads. Button batteries I have 2 stars next to because this is probably the most dangerous thing that kids can put into their nose. Alkaline batteries can corrode the nasal septum, and so this can result in necrosis of the nasal passages in as soon as 7 hours. So if a kid has a button battery up their nose, you need to get this out ASAP or it can actually do some significant damage. Most of the kids that are going to be doing this are in the ages of 2 to 5. My daughter did this one day at school when she was about 3.5. I came to pick her up from school and I took her to the bathroom at school and she sneezed a couple times and a purple bead came shooting out of her nose. And I asked her, I said, where did that come from? And she goes, oh, Mommy, I feel much better now. Apparently she had stuck it up there a while ago and forgotten about it, but she knew that her nose was bugging her. So fortunately that one came out on its own because I didn't even know it was in there. The cardinal sign of a foreign body in the nose is foul-smelling discharge from only one nostril. So there's some tricks for removal, and I posted a video about how to get things out of noses. The easiest way, if you have a kid who can cooperate, is to have them hold the clear nostril closed and then blow their nose. A lot of kids won't cooperate with this. The forceps and cerumen loops can be really scary to kids. Probably the easiest way to do this is to have a parent occlude the opposite nostril and then blow into the kid's mouth, and this will create enough pressure that it shoots the object out, and we call this the parent's kiss. As a healthcare provider, you don't want to be putting your mouth on kids' mouths unless there's an absolute emergency, so you can do this with a bag mask as well. You're just going to make sure you have a very tight seal over their mouth and block the opposite nostril. Oh, sorry. Okay, so the next thing that we need to be worried about with the nose is nose bleeding. So nose bleeding can either be anterior or posterior, and it can range from anything from mild to life-threatening. So the most common anterior area for nose bleeding is this Kieselbach plexus up in the front. Some of these big arteries in the back can bleed, and these can be really hard to stop. So posterior bleeding especially is very challenging to control. It's hard to visualize the source and it may not respond as well to typical measures. So you may need to involve otolaryngology, and these patients can bleed quite a bit quite quickly. If a patient needs posterior packing or a nasal balloon to stop the bleeding, so those both provide pressure on the back of the nose, they should also be given some antibiotics because they're likely, you're introducing a potential infection. You can refer to outpatient management to ENT to consider cautery, especially if they're having recurrent nosebleeds, and you need to be monitoring blood volume. Always when you're managing these patients, think about airway, breathing, circulation, make sure they're getting enough blood flow. Direct pressure should stop most of these within 5 to 15 minutes. Patients should be taught to lean forward so that they don't aspirate. And then I think the easiest way to deal with this, especially with outpatients, this is something you can teach parents of kids or even adults who get frequent nosebleeds, is to keep a bottle of Afrin in their purse. And then you can take in a tampon. You take a small tampon, soak it in Afrin, and shove it up your nose, and it provides both pressure and a vasoconstriction that can help stop the nosebleed. A nasal septal hematoma is a hematoma or collection of blood that results in the chondral tissues, so those cartilage tissues That happens when small blood vessels rupture alongside these chondral tissues. The problem is that this is a very small space, and this blood that's pooling in this area can cause some tissue necrosis and ischemia of those tissues, and that can result in either a septal perforation or the saddle nose deformity, which you see on the bottom here. So when a patient has a history of blunt nasal trauma, most of the time they're really worried about whether or not their nose is broken, and quite honestly, that's not as big of a concern. The bigger concern is a nasal septal hematoma. If you see this, it'll look like a bluish mass that's kind of protruding from the nasal septum inside the nose. So treatment of this is that these patients need to be dealt with by otolaryngology or ENT. They need incision and drainage, usually under anesthesia. They may need some packing, and they may need some antibiotics. All right, let's move on to the ear. So some auricular and auditory red flags. So remember, your ear has, it's not just the structure, but also the function, and the function is the hearing. So any sudden loss of hearing, whether unilateral, bilateral, is a concern. Pain, drainage, and bleeding from the ear can indicate that there's either a severe infection or a rupture of the tympanic membrane. Dizziness and unilateral tinnitus can be a concern. Trauma to the ear should warrant some treatment, and then foreign bodies or pus in the ear canal are also concerning. So let's get into some of the things you might see in primary care. Again, foreign bodies are quite common. Kids like to put things in holes, although kids tend to put things in their ears a little bit older, and they tend to be smaller things like beads, rocks, toys, paper, and then again, those pesky button batteries we need to be really careful about. If the patient has a sensation of movement and pain, the likely cause is actually an insect, which is pretty gross. But the key to removing insects from the ear is that you want to kill the bug before you try to remove it. So you can put some alcohol solution, mineral oil, or lidocaine into the ear canal as long as the tympanic membrane is not perforated. So if the tympanic membrane is intact, or you think it's intact, or you have no reason to doubt that it's intact, you can kill the bug by putting the solution into the ear first, and then removing it with either a hook or forceps or with irrigation. Again, irrigation can only be done if the eardrum is intact, and you want to be careful with irrigation too if you have an organic item in there. So for example, a bean or a pea, the moisture from the irrigation can cause the item to swell, and so you don't want that because then it's harder to get out. So just as a tip too, if you have something like a button battery that's magnetic, you may be able to use a magnet to pull whatever it is out of the ear. The next thing we're going to talk about is auricular hematoma. This is pretty common, especially in wrestlers and boxers who get hit in the sides of the ear. This is a damage to the skin, subcutaneous tissue, and perichondrium in which they are separated from the cartilage underneath, and this creates a hematoma, and again, it can cause an impaired vascular supply, much like the nasal septal hematoma, and so that results in that kind of disfiguring appearance of cauliflower ear. So there are specific treatments for this, and they're probably a little bit beyond what you're likely going to do in primary care unless this is something you see a lot of. For example, if you're the medical person who handles, like if you're working in sports medicine practice and you volunteer with the sports team for a wrestling team or boxing team. But these need to be evacuated, and then there's a bolster dressing, which is a pressure dressing that we put on the side of the ear to support this. Mastoiditis is not exactly an ear problem, but it's a complication of an otitis media. So this is a progression of the infection of an otitis media into the mastoid sinuses that are located, or into the mastoid air cells that are located behind the ear. Most of the time this happens in children over 3, particularly because these mastoid air cells are not fully developed until after the age of 3, but it can happen earlier in a child who develops earlier. This will cause swelling behind the ear and redness, and this will turn the ear forward and kind of protrude the ear forward and downward and outward. This can actually end up becoming very, very complicated, including spreading to the meninges or the cerebral blood vessels. So these patients need to be admitted with hospitalization. They need broad-spectrum antibiotics, and they may need surgery to create what's called a mastoid bowl, which is where they scoop out all those air cells behind the ear. All right, and lastly, we're going to get into the oral and throat emergencies. So a couple of red flags when you're talking about oral and throat emergencies. Any pharyngitis that's worsening and lasting worsening and lasting more than 5 days. It is possible. Most of the time we think of pharyngitis as being relatively self-limited, even if it's a strep infection. There is a type of infection called Lemire syndrome that is a bacterial infection caused by Fusobacterium species, and this is going to test negative with the strep test, but it can be potentially life-threatening. And the natural course of this disorder is that the patient will initially get better and then get worse again after 5 days. So if you see that, or if the patient's just continually getting worse despite treatment, that's something to be concerned about. Fever over 102 is more likely to be a bacterial or more severe infection. If the sore throat comes back after several days, again, especially if it's associated with severe fever, chills, or night sweats, that can indicate that Lemire syndrome with the Fusobacterium species infection. If there's any airway compromise, unilateral neck swelling, those are two things that we get really concerned about, and we'll talk about the conditions that can indicate. And then finally, anytime you have a patient who presents with pharyngitis, you need to be thinking about the possibility of this being an acute HIV infection. So keep in mind, unprotected sex within 2 to 4 weeks could indicate that that's what this is. So keep that on your radar. All right, so an airway foreign body is a pretty common thing. Kids inhale things especially, but adults actually do too. The first thing that you're going to do is secure an airway, and this may involve some invasive life-saving maneuver. So you may start with a Heimlich maneuver. You may have to do a jaw thrust in either a nasal or oral airway. If a patient doesn't respond, this might require direct laryngoscopy and removal of the object. An ET tube placement past the level of the obstruction may be necessary. So patients who have a partial obstruction can be a little bit tricky because they can come in with symptoms that sort of mimic a sudden onset of croup, so cough, gagging, wheezing. In this scenario, the provider needs to have a high index of suspicion and consider getting x-rays. Dyspnea, stridor, and respiratory distress are more likely the more complete the obstruction. So the method of removal for this is going to depend on the patient's age and oxygen status. Again, we need to be very, very concerned about magnets and button batteries. So magnets, so you know about button batteries and they can cause necrosis. The issue with magnets is that if there's more than one magnet in there, they can start moving towards each other, and so that can cause tissue damage if they destroy the tissue in between. So the primary goal of this is going to be to get this airway secured and then get the patient to an appropriate provider who can help get this out. A retropharyngeal abscess is not tremendously common, but it is something that can happen as a consequence of a respiratory infection, an upper respiratory infection. So the presentation of this is that children will be about 5 or 6 years old, maybe a little bit older. They will have a recent URI. They will have a newer onset of fever, neck pain, sore throat, and trouble swallowing. They're going to start demonstrating, they may, if it gets severe, they may have torticollis or leaning to one side. That's that unilateral neck swelling. They may start drooling because they can't swallow their saliva, and they may have stridor. Have a very, very high clinical index of suspicion that something is much more serious if ever you have a school-aged child with a sore throat and an inability to swallow their saliva. That is a huge red flag. Drooling is not appropriate in a child that age, so that should tell you that this is way more than just a sore throat. These patients are managed with a CT of the neck to confirm that this is the problem. They need ENT consultation, IV antibiotics, and they may end up needing surgery for incision and drainage. A peritonsillar abscess is a little bit similar, but the age of onset tends to be a little bit older. These patients will have a sore throat, fever, drooling, and a muffled voice. This is basic. When you look at their tonsils, you'll see that one of their tonsils is significantly larger than the other, even if they both appear red, and the uvula will deviate away from the infection. So again, management of this is CT of the neck, ENT consult, IV antibiotics, and a possible surgical IND. So post-tonsillectomy concerns. Most patients who are going to bleed after a tonsillectomy are going to do so within the first 24 hours. That's about 2.2% of patients who have a tonsillectomy. Or they can bleed at a second time, which is between days 5 and 8 when the scabs fall off, and that's the other 3%. These parents need to be aware that the kid may have excessive swallowing or present with bloody emesis. So if we see bleeding after tonsillectomy, we want to make sure that we're applying pressure. Epinephrine and thrombin can be applied. Surgical management may be required, and these patients may need resuscitated if the bleeding is concerning. If a patient's presenting with severe pain, typically they're going to look dehydrated, and this is going to be because they didn't drink enough fluids. Dehydration will actually exacerbate the pain. NSAIDs and acetaminophen are the preferred treatments for children of this age, but there are others as well. Other pain medications we can use. We just like to reserve them because a lot of times kids are very sensitive to them. One more complication that we sometimes see of the throat is epiglottitis. Epiglottitis is a swelling of the epiglottis that occurs due to infection, and this occurs in children ages 2 through 6 primarily. They will have upper respiratory infection symptoms with a severe sore throat. Again, that drooling will come back, and they may have a tripod posture, so they kind of prop themselves forward in an effort to support their breathing. They may look cyanotic or have stridor. On on lateral x-ray of the neck, you may see what's called a thumb sign, which is where you can see the swelling of the epiglottis here. And the management of this is going to be steroids, IV fluids, and airway management. Lastly, it's not uncommon to see oral trauma in children. Typically, this is caused by a fall with a foreign object in the mouth, so a toothbrush, a pencil, etc., or even a fork or a spoon. These patients are going to present with pain, drooling, and bloody emesis. Airway protection is the key here. Most of these things are going to heal on their own, but we just need to make sure that the swelling is not so severe that it's going to cut off their airway. We used to admit these patients to the hospital for a couple of days to keep an eye on them, but there's not really any evidence that that works better than just watching them closely at home. So you're just going to need to teach parents what to watch out for, how to make sure that they're managing their airway appropriately. All right, so that sums up our presentation on HEENT red flags and emergencies. If you have any questions, appreciate if you'd post them to the office hours page. Thanks so much.